Good evening, esteemed members of the Pharmaceutical Society of Kenya. Good evening, senior respected members of the Pharmaceutical Society of Kenya. And good evening, honorable fellows who are joining us for this wonderful meeting today evening, and all other allied healthcare workers who are joining us. Today's meeting is on the common causes of coughs and the management. The common causes of cough and the management. We are privileged to have Dr. Andrew Award, a consultant physician in matters respiratory and critical care specialist at the United National Hospital. As is our norm, I will probably for our speaker and probably for our great partner for this meeting, who is none other than Cosmos Pharmaceuticals, a local manufacturer, the #1 local manufacturer in the country, for them to probably understand where we are joining from. I would like on the chat box, just say hello and let me know where you're joining us from, and let me know which branch you're joining us from or which part of the country. Also, the PSK branch you belong. For the other healthcare workers, let me know which is your major town from which you're joining us from. We'll begin this meeting when we get to number 250 or thereabouts, or 7:05 p.m. We do either or. So let me see on the chat box for those who are joining us. Where are you joining us from? And what's your name and where are you joining us from? I can see Dr. Lucas Nyabero, the CEO of PSK, is joining us from Nairobi branch. Ladies and gentlemen, esteemed members of the Pharmaceutical Society of Kenya, senior respected members of the Pharmaceutical Society of Kenya, and honorable fellows and other allied healthcare workers, I do wish to welcome you to this meeting today. This meeting is in partnership with Cosmos Pharmaceuticals, who say medicine you can trust. It's on the common causes of coughs and the management of that, and it's been conducted by none other than Dr. Andrew Award, a consultant physician in respiratory and critical care specialist at the Kenyatta National Hospital. A humble request is just for you to tell us where you're joining us from, and what is your name and where you're joining us from. Just type in on the chat box, where are you joining us from? I'm waiting to see that. Anybody who's able to type on the chat box? Oh, chat has been disabled. I hear you. Okay, I'm getting a call that chat has been disabled. Let me. Everyone, are you able now to? Wonderful. I have enabled it back. Probably. Karibu once more, ladies and gentlemen, for today's webinar. We're joining in and we'll begin in the next 3 minutes. Let me know where you're joining us from, which branch of PSK you are joining us from. Thank you, Dr. Rajab from Coast Branch, Dr. Tadudi from Coast Branch, Dr. Jasprit from Coast Branch, Dr. Riziki from South Rift, Dr. Jitesh Meru, wow, Dr. Catherine Wambura, that is Nairobi, Dr. Muchonjo from South Nyanza, that's a lecturer from South Nyanza. Dr. Pauline, Sister Pauline Congo, joining us from South Sudan. Karibu sana, Daktari. Muhammad from Equity Afya Pangani, Karibu sana. Dr. Kayla Barasa from Nairobi, Karibu sana. Dr. Jayesh, pharmacovigilance expert from Nairobi, Karibu sana. Wow, Dr. Valerie Naitore from Meru County. Dr. Beatrice Omboy from Kiambu. Wonderful, wonderful. Evans from Turkana. Ladies and gentlemen, I had promised 250 or thereabouts, or 7:05. Let me take this wonderful opportunity to say Karibu sana to today's webinar. My name is Mbao Gita. I'll be your host today. This meeting is in partnership with Cosmos Pharmaceuticals Limited. That's a local manufacturer and a local manufacturer of National Hospital. I will go to a few ground rules just before we begin. So a few ground rules just before we begin is that first and foremost, thank you so very much for participating in this session. All participants are muted during the entire course of this session. Please ask the questions via the Q&A tab at the bottom of your window. Questions shall be addressed by the presenters on the Q&A tab. For PSK members and for members of the Pharmaceutical Society of Kenya and also the pharmaceutical technologist, if not already done so, please subscribe on the PPP portal for these videos. A point to note is that this session is being recorded and it will be made available on PSK's YouTube page. So probably welcoming remarks, dear ladies and gentlemen, I do wish now to take this wonderful opportunity to take this opportunity to welcome none other than the CEO of PSK to give his opening remarks. Just before I allow him to speak, allow me to introduce to you none other than our CEO, Dr. Lucas Nebero. He is a holder in PharmD. He is also a current an MPSK, a member of the Pharmaceutical Society of Kenya. He's a holder of a PharmD from the Massachusetts College of Pharmacy and Health Sciences. He is also an adjunct faculty at United States International University of Africa, and also an adjunct faculty at the Massachusetts College of Pharmacy and Health Sciences. Ladies and gentlemen, I do wish now to welcome none other than Dr. Lucas Nebero for his opening remarks. Dr. Are you with us?
Another go. Yes, I am. I am with you, Dr. Mbao.
Karibu sana for your opening remarks, Dr.
So for all the members, hello and good evening. Thank you so much for being with us. This is so cool that we get to see where you're calling from, and that's really nice to see how far we've gone. We're very, very proud of you folks, and thanks for joining us. Also, thanks for Cosmos for being very generous to support this particular webinar. Dr. War for joining us too. So at this point, I'll just say I'm also strapped in to learn and understand. And again, PSK is here for you. We are here to support you. Be with us. Talk to your friends about joining PSK so that we can have the strength that we need to push things around. I really do appreciate everyone. The last thing is that if you got a chance if you got the survey, the Doctor of Pharmacy or the PharmD survey, please fill it up for us. We're trying to collect data so that we can make sure that whatever we do, we have input from everyone. Without much ado, I'll pass it back to Dr. Bao. You're doing a very good job, and go for it. And I will be sitting back to learn. Thank you again, Dr. Andrew, for joining us, and looking forward to the hour. Thanks.
Asante sana daktari. So now, without further much ado, ladies and gentlemen, I think we are all here. We are all eager to listen to and learn from none other than the great Dr. Andrew Ward. Daktari, are you with us? Dr. Andrew?
Yes, I am.
Perfectly in. So, ladies and gentlemen, allow me to welcome now, and it is my greatest pleasure to welcome none other than Dr. Andrew Ward. He is a consultant physician in matters respiratory and critical care specialist at the Kenyatta National Hospital. Dr. Andrew, it is your people are my people.
Asante. Thank you so much, Pharmaceutical Society of Kenya and Cosmos, for yet another occasion for me to be talking and sharing knowledge with dear colleagues. Gives me really great pleasure. I think the last time I had a large turnout, I think the largest talks that I've given is to this group. You always wow me. I think I gave a talk and there were almost 2,000 people listening. So let's see if today probably that record will be broken. As usual, you guys are fantastic. And there are lots of questions, so I'll be prepared. So my task today is Okay, I think somebody has said they haven't seen me, so let me just try and okay. I think you've seen my face. I'll try and mute the video so that I can, so that we can keep the bandwidth, so that there are no interruptions with the audio. So my task today is common causes of cough, and to give a brief rationale on the management of the common causes of cough. As a respiratory physician, this is going to be an interesting talk, and I can't wait for the questions. So this is a sponsored talk. Most of the opinions here are my own. I've prepared this presentation. This is the outline. We're going to go through the definition and pathophysiology of cough. Somebody had a problem pronouncing pathophysiology, but just basically means just the basis of how this cough arises, etiologies of cough, the common causes, and an approach to their management. So this is a diagram or a picture showing you a male, a human being, just showing you the respiratory system, because cough is probably one of the commonest manifestations of issues with the respiratory system. And remember, the respiratory system starts at the nose. The oral cavity participates. Then you go to the pharynx, and then you want to move to your larynx down here where your voice comes in, and then your trachea, which is your windpipe, and then it divides into two, to the left and right main bronchus, which usually go into your lungs. The other thing is your lungs actually sit in a cavity, and they are covered by something called a pleura. Okay, so the lungs are not stuck to your chest wall. There's usually a small space called the pleura, okay, that is in there. And then at the bottom of your chest wall, there's usually a big muscle called a diaphragm that helps in breathing. Actually, without this big muscle, breathing is a challenge. So usually when you want to talk about cough, you'll want to find out where could the problem be in this whole part anatomy of the respiratory system. So the most common signs and symptoms for respiratory diseases will usually be cough. I think I'd say probably 90% of the signs or symptoms in respiratory diseases will be a cough. You may have wheezing, you may have shortness of breath, what in the medical we call dyspnea. The patient may have cyanosis, low oxygen, and then occasionally, the slightest occasion, the patient may actually have pain around the chest. Okay, so it is important to remember this, because if somebody comes to you and they are complaining about a cough, you want to ask if they have these other symptoms. If they have wheezing, I guess even your grandmother would know what the diagnosis is when somebody is wheezing. If the patient has shortness of breath, then it means it's not just it's not as simple as you think. If the patient has cyanosis, which is actually darkening of visually the extremities, and then if the patient also complains of pain around the chest, these are cases where you actually would need to refer this patient to actually a medical colleague. So what's the definition of a cough? So the definition of a cough is actually a description. So it's a forced expiration, which is forced breathing out against a closed glottis. A glottis is actually your larynx. So you actually breathe out while your larynx or your vocal cords are closed, okay? Which usually suddenly opens to expel air and unwanted material. And that's why there's that guttural noise, okay? Because remember, noise or voice is always be projected from the vocal cords. If the vocal cords are not working, then barely, even if you cough, we'll barely be able to hear it, okay? So suddenly, usually somebody expels air or unwanted material from the respiratory tract. It may be voluntary or involuntary, okay? So for example, if you're choking on your chicken right now, as you have your dinner, that is what you'll actually say involuntary, okay? If somebody cracks a joke and you don't want to laugh, you can usually voluntarily cough, okay? So Cough is actually a reflex that is designed to protect your respiratory tract. And it is actually a natural response. So I try and explain to my clients that the reason why you have a cough is because a cough is part of survival for a human being. That's why you cough, okay? If you didn't cough, many things would go unnoticed, and that's why it's important for you to cough. Now, what's the pathogenesis? Now, this is a complex diagram, maybe for people like me, but we'll probably start in the lung, okay, or in the respiratory system. So there are nerves, okay, there are nerves from the respiratory system that go all the way to the brain. And remember, the brain is the one that controls each and every part of the body. Each and every organ is under the control of the brain. So this is the most important organ in a human being, and actually makes the difference between us human beings and animals, because we have very huge brains for the size of our bodies. Now, the nerve that is actually responsible for this is actually called the vagus nerve, okay? And it sends messages from the airway to the brain and back. And then the brain will send messages back to the respiratory system via this nerve. Now, for this cough to happen, there are several things that need to be there. So one is there needs to be an irritant. Are you getting me? So there has to be an irritant in the airway. So this is a snapshot of the airway. Okay, the airway mucosa. This is how your airway looks like. There are these small things here which are called cilia. These are the things that usually move up secretions from your air, from your deep in your lungs to your windpipe and out. So usually, sometimes if you cough, there'll usually be sputum. So these finger-like things are what actually are in your respiratory system. We call them cilia. And when they are working well, then you're usually able to actually remove your sputum. There are certain diseases that actually these are affected in what we call congenital diseases. This will usually be pediatrics. Our focus today will be in adults. So and they usually move in one direction. So they usually move towards the upper side. So they usually move in one way to try and remove anything that is in the lungs, so that it can come up to your major bronchi, to your trachea or your windpipe, and then you cough it out. So that's your airway mucosa, okay? And your airway mucosa has sensitivity. There are receptors in the airway. They are called transient receptor potential, okay? TRP family of receptors. They're usually mainly involved in airway, chronic airway inflammation. So they're receptors, and they'll usually be an irritant. And an irritant can be anything. It can be capsaicin, it can be acid, it can be inflammatory like bradykinin or prostaglandin, or it can be mechanical, like particulates, food matter, okay, if you aspirate. It can be nicotine, smoking, or it can be low chloride, which will usually cause you to cough. Now, there are cough receptors in your airway, and of course, these receptors will usually be attached to your nerves, and that's how the messages will be sent. So there'll usually be a trigger, okay, which will usually cause hypersensitivity of your airway. So there are triggers like here. The airway is very sensitive, so they'll trigger. Okay, they'll trigger the airway mucosa. The cough receptors will relay the message through the nerves to the brain. Okay, and then the brain will usually send back a message and say, okay, there's food particle in the trachea, cough it out. And these messages will usually be sent to the muscles, which is the diaphragm, to the trachea, to this cilia. There, you see there are nerves here. The messages will come back and you'll be able to cough out. So in your brain, you have something which is called a respiratory center. So this is a part of brain that controls breathing, okay? Which, for example, if you're given some substances that depress the respiratory center, and I'm sure you guys know some of the respiratory depressants, for example, benzodiazepines or opioids, then they would diminish the respiratory center. So one, you may not be able to cough, and two, you may not be able to breathe. And that's why those drugs, for example, have to be used with caution. Then there's a voluntary part of the brain. Okay, so usually this can be through emotional pain. Okay, if you're getting a thorough beating, you may actually cough. Or if you're excited, you may cough. Or if you're laughing so hard, you're so excited, you may actually have what you call a voluntary cough, which is actually a part of the brain that is responsible for this. Now, the cough center is in somewhere called the nucleus tractus solitarius in the medulla. You don't need to know this. This is just for presentation purposes. Now, for the cough to happen, there are several phases. There's the irritation phase, as I mentioned. So there are several things that can irritate you. Then the inspiratory phase, where there's a brief inspiration, the glottis opens, the diaphragm contracts, and the thoracic cage expands. And then the compressive phase, where now the abdominal muscles come in, and you actually, through a closed glottis, and that's when you actually have finally an expulsive phase, where you actually cough that thing out. Okay, usually up the glottis or the vocal cord will open up abruptly, and then you'll have a rapid exhalation at high velocity to be able to clear your whole airway. So that's basically how you end up having a cough. That's the pathophysiology of cough. Now, we've had cough guidelines. The first ones were established around 1998. First international guidelines on cough. They're summarized depending on their physiology, and cough was divided depending on the duration, either less than 3 weeks, which would be acute, or 3 to 8 weeks, which would be chronic. Okay. However, it never truly addressed chronic or inexplicable cough of more than 8 weeks duration. But this was a step forward, because for the first time, we actually had something that we could use to actually be able to help us to decide on how to manage coughs. Then there was a review, a second international guideline on cough, and now they divided cough into 3, which was acute cough, which is less than 3 weeks, which is important when somebody comes to you. You want to know, is this cough acute, subacute, or chronic? Okay. Again, this addressed the common diagnosis and their treatments, and the different diagnoses that were there. Okay, for each category, which was a step forward. And then lastly, in 2018, we actually had the third international guideline on cough, which was an update of the 2006. They maintained the 3 cough into 3 classes. So acute, less than 3 weeks, subacute, 3 to 8 weeks, chronic, more than 8 weeks. Okay. And what was important is that the definitions were being used around the globe, and we actually came up with what we call management algorithms, which help to predict the common causes of acute, subacute, and chronic cough. And I'll actually move to that in the next slide. Now, this is actually an algorithm. This is how we manage patients with cough. Okay, sorry about that. So for a patient with an acute cough, that is a cough less than 2 weeks, you want to find out from the history. You want to ask, you want to do a history. Now, I know most of you may not be able to do physical examinations because you're not trained in that. Somebody will usually come and they say, I'm having a cough, I want a solution. And we know Kenyans will usually go to pharmacists and chemists first before they actually go to Medic, and this is actually data that has actually been published. So there's a big role for you in terms of helping us manage patients. So the things that you want to know is this life-threatening or not? Okay, life-threatening are patients who have pneumonia. This one you'll be able to see the patient can hardly finish their sentences. They're out of breath, or a severe exacerbation of asthma. Okay, all right, patient will usually be wheezing, or COPD, which is chronic obstructive pulmonary disease. I gave a talk the last time about this. Or a patient with pulmonary embolism. Now, the thing about this group of patients, they're usually extremely breathless, or a patient who has heart failure. Okay, now these ones will need to be evaluated and treated very quickly. So these are a group of patients who I don't expect any of you to try and treat. It's basically to refer this group of patients to a medical facility. If a patient is obviously breathless, can't finish their sentences, is breathing very hard, you need to refer this patient. They need to be evaluated by a medic. These are the ones which you call red flags. Anything that is red flag, please don't try and manage. Then, if the patient is not having any of those red flags, then you can say this non-life-threatening diagnosis. Now, what are the common causes of cough acutely? Less than 2 weeks is 1, infectious or non-infectious causes of cough. Now, how would you know somebody has an infectious cause of the cough? If you have an infection, you will have fever. If a patient doesn't have fever, it is unlikely they have an infection. And I'd recommend in all your outlets to at least have that thermal gun so that you can check everybody's temperature whenever they come to your facility. If they are coughing, check their temperature. If they are not coughing, still check their temperature. Okay, all right? Because we are here to help humanity, because we are actually custodians of human health. So it can actually be a lower respiratory tract or an upper respiratory tract infection. Lower respiratory tract infection, this means it's below the vocal cord. And upper respiratory tract infections is above the vocal cord. So if you have an infection, for example, a laryngitis, then it will be upper respiratory tract infection, or a pharyngitis. So these patients usually present with sore throat. If a patient has a lower respiratory tract infection, they usually cough. So if somebody presents with a cough, then it means it's something down here. Upper respiratory tract, majorly sore throat. I'm having a sore throat. When they start having a cough, then things probably have moved a bit downwards. Now, when a patient has a cough, you want to find out, is it acute bronchitis? Okay, or could it be pertussis, which is a common cause of infection? Or for our region, then TB is a consideration. Okay, so now for anybody who has, again, infectious causes, these are patients who you want to refer. Okay, because this patient will actually need to be examined to check whether it's a LRTI or a URTI, and they may actually, for a lower respiratory tract infection, this patient will actually need to have a chest X-ray done. Okay. Now, then there are those ones that, again, that are not infectious. So this patient does not have a fever and has an acute cough. So the question is this: does this patient have asthma? Okay, and this is very common. Okay. Then the other thing is, does this patient have bronchiectasis? Okay, these are patients who have pre-existing lung disease. Probably they had TB in the past, and now they're presenting with copious amounts of sputum and cough. Or do they have what we call upper airway cough syndrome, formerly called a postnasal drip? Okay, or do they have COPD, or is it something else? Now, things to be worried about is this patient coughing blood? That's a red flag. Is this patient a smoker? You must always ask, you smoke? If somebody smokes and they're above 45 with a new cough, this one is something that requires further evaluation. If the patient is elderly, 55 to 90 years, and they were smoking, okay, they were smoking, they are either currently smoking or they stopped smoking in the last 15 years, this is a red flag. These are the group of patients who usually tend to have what you call COPD. Or this patient has prominent shortness of breath, okay? Right? They are dyspneic, okay? All right, especially at rest or at night. Or this cough is actually worse at night. If the cough is worse at night, you want to think about asthma number one. Always ask anybody showing up with a cough, if they say their cough is worse at night or worse when it gets cold, when they're exposed to dust, smoke, and all these things, asthma is top of your list. Okay, then hoarseness of voice is a red flag. Okay, then danger signs. If the patient has fever, weight loss, okay, you want to think about an infection. And if the patient has weight loss, then you want to think about TB. And then if the patient has peripheral edema, okay, which means their legs are swelling, okay, then you want to think about heart failure, okay, right? These are serious signs. And then if the patient has trouble swallowing, okay, when eating or drinking, you want to think probably of this patient could be having some reflux, or this patient is vomiting. Okay, the patient is coughing until they are now vomiting. That means that, I'll say, except in children, if an adult coughs until they vomit, there's a problem. Or this patient has a history of pneumonia, or if you're able to know how to examine the patient, they have abnormal findings, or they've just done a radiograph that shows that they actually have an abnormality. Okay, this will actually mean there's something wrong. So for acute coughs, now life-threatening, non-life-threatening. Life-threatening, refer to a medic. Non-life-threatening, is it an infection or not? Are we together? Infection, patient will have fever, they may have a headache, muscle pains, and the like. Basically, it means it's something systemic. Or this patient actually doesn't have an infection, then it's actually an exacerbation of a pre-existing condition. And these are the common causes, okay? Our topic today is common causes: asthma, bronchiectasis, upper airway cough syndrome, COPD, and others. What about a patient presenting with a cough that has been there for between 3 to 8 weeks? Okay, so these are patients who you want again to ask yourself, do they have life-threatening diagnosis or not? Okay, now if it's 3 to 8 weeks, then you expect that this will actually be a non-infectious. Okay, so you want to think about workup for a chronic cough. Okay. Okay, so again, life-threatening, non-life-threatening. Okay, if they are life-threatening, refer. If a patient, and if the patient has post-infectious, these are some of the diagnoses that actually could be life-threatening. Pertussis, COPD, post-infectious, TB is still a concern, 3 to 8 weeks. Anybody coughing for a duration of more than 2 weeks, TB is actually a differential in Kenya. We have a lot of TB. Okay, now if the patient doesn't have fever, okay, then infection is unlikely. And if the patient had fever, then this patient may now be having what you now call a post-infectious cough, okay, either due to any of those. Now, if you can elicit that the patient does not have a post-infectious cough or an infectious cough, then you want to ask yourself, again, what are the common causes of a subacute cough? Will usually be either new or an exacerbation of an existing condition. Again, upper air cough syndrome, asthma. Here now, the person who joins us here is somebody called GRD, or Gastroesophageal Reflux Disease. Bronchitis comes in. Bronchiectasis was there even for acute. And for bronchitis, there's this term called non-asthmatic eosinophilic bronchitis. And then you can actually have COPD. Again, the danger signs are here: fever, weight loss, swelling of the legs, patient who's coughing blood, anybody above 45 who smokes, or people who are above 55 to 90 years with a previous history of smoking. Patient who's had pneumonias, patients who are vomiting, patients who are having challenges with swallowing. Now you want to think about gastroesophageal reflux disease. What about a chronic cough? Okay, so for patients with chronic cough, these ones you want to first of all make sure that they don't have the red flags. You want to find out about occupational or environmental issues. Is this patient exposed to dust or chemicals in the occupation? For example, I'll give you hairdressers in town. Okay, they're exposed to all these hair chemicals, or people working in the salons. Okay, so you want to ask, what do you do? Okay, where have you traveled? Because travel is important. Because if you get this history of travel, this is where now COVID came in. Okay, people who are traveled. Okay, if you're in Kitale, na mtu amesema ametoka Nairobi, you want to, and they're coughing, you want to ask, you want to start thinking about, could this be actually an infectious cause, especially if they have fever? Then COVID-19 is one of the things. And then exposures, okay? People, for example, carpenters, masons who are exposed to dust, welders, are you getting me? These are people who they're exposed because of their occupation. And then also where somebody lives. Do they live near a factory? Okay, or do they live near somewhere where there's a lot of exposure to dust? Do they live near a highway? Because cars are always passing by. So you want to find out life-threatening conditions. Are they there? If they're there, they need to be investigated and treated. Okay. And then 2 is for chronic coughs, these are patients who need a physical exam and must have a chest radiograph. So these are people you want to refer. Are we together? Some of the rarer causes of actually a chronic cough, for example, if as a patient, you have to ask this patient, do you smoke? Are you hypertensive? Because you know some of the drugs that you use for blood pressure control, for example, the ACE inhibitors or the angiotensin receptor blockers, the ARBs, can actually, enalapril, ramipril, and the like, can actually cause a cough. And then there's this new drug, sitagliptin, for diabetes. Even for me, I did not know sitagliptin causes a cough. Actually, I saw a patient yesterday, and luckily I'd been preparing for this presentation, so I was actually able to get the patient off the sitagliptin. This is what we call a dipeptidase inhibitor, DPP4 inhibitor. Okay, it actually can cause a cough. If you find the patient is doing any of these, if they're smoking, you want them to discontinue smoking. If they're on an ACE inhibitor or an ARB, then you want to discontinue. If they're on sitagliptin, you want to discontinue. that medication. Okay. Now, for the common causes of cough, okay, for patients who are chronic, this is what I will do, because these are patients who you will refer to somebody like me. So most common causes for chronic cough, upper air cough syndrome, and usually this is what you formally call the postnasal drip syndrome. These are patients who usually have rhinosinusitis. Okay, so these are patients who want to do sinus imaging. We want to check, do an esophageal. Sometimes, if we actually may not have facility to be able to do this, these are patients who you want to try on allergy medication. So allergy evaluation for empiric treatment. So these are patients who empirically put on anti-allergy medication, usually antihistamines, and try and see if the cough resolves. For patients who we suspect to be asthmatic, I told you for asthmatic patients, for the upper airway cough syndrome, these are patients who usually complain that they actually have a drip at the back of their nose. For asthma patients, these patients cough a lot at night. They don't sleep. So if somebody says they can't sleep because of their cough, this is one of the most likely causes, okay? Asthma. Or their cough gets worse when they're exposed to cold air, when it gets cold, or early in the morning, or when they're exposed to dust, when they're exposed to perfumes, strong smells typically, will usually irritate them. Are you getting me? Then these are patients, and asthma is basically very hypersensitive or hyperresponsive airways. Now, these patients are typically usually do what he calls spirometry with bronchodilator reversibility. Where this is not, where this doesn't give me a result, I may do bronchoprovocation. So I give the patient an irritant, like you saw in my initial slide. Give the patient an irritant, usually use methacholine, and then we see if this patient's lung function deteriorates. Okay, we may usually also evaluate this patient for allergy, simply because asthma is in the group of illnesses called allergy. So allergy is a broad term for 5 major diseases. The first one is usually allergic conjunctivitis. The second one is allergic rhinitis. Allergic conjunctivitis is usually itchiness of the eyes. Allergic rhinitis, the second one, basically this is sneezing, especially in the morning. We're exposed to dust. That's allergic rhinitis. The third one is asthma. Okay, either usually be cough. Okay, the patient may sometimes complain of chest tightness. They may sometimes wheeze, and from time to time, they may experience shortness of breath. That comes in because it's not there every day. For an asthmatic, the symptoms are different depending on different days. So today they are bad, tomorrow they're okay. So the patient may be coughing so badly today, tomorrow when they wake up, they're fine. And then in the evening, they're coughing again. So usually you want to think about asthma, okay? And its sisters. The fourth one would be allergic dermatitis or eczema, okay? All right, so if the patient comes to you and they're coughing and they also have a rash that is itchy, then asthma is top of the list again, okay? So eczema and asthma, those ones will work together, okay? And then the last one is food allergy, usually to protein. So if somebody has protein allergy and they come in with a cough, asthma is your likely diagnosis. And you'll see that asthma features quite a lot, because majority of patients in the community who have this subacute to chronic coughs, this is actually one of the causes. Then non-xenophilic bronchitis, this is rare. Okay, this one is probably the one who may probably be able to make a diagnosis, but you want to find out that this patient have a history of allergies. Okay, do they have allergic conjunctivitis, itchiness of the eyes, running nose, or sneezing a lot in the morning? Do they cough at night? Okay, do they have itchiness of the skin that comes and goes? And do they have allergy to protein? Usually meat, fish, chicken. The most likely culprits, usually they are allergic to eggs. Okay, so somebody says, oh, when I eat eggs, I start itching, or I have a lot of stomach pain, and they are coughing, then you want to think about either non-asthmatic eosinophilic bronchitis or asthma. Management for those two is usually the same. Then for gastroesophageal reflux, you want to ask, does this patient have heartburn? If a patient complains of heartburn or they have the problem swallowing, then you want to think about reflux. Here, the management is actually acid suppression together. So initial treatments usually for upper air cough syndrome, we'll usually use antihistamines. For asthma, we'll usually use inhaled corticosteroids. Sometimes we may actually, which is a backbone. Do not give patients Ventolin. It does not treat asthma. It only treats the symptom. Treatment for asthma is an inhaled corticosteroid. A bronchodilator will usually be given for relief, okay? But the recent guideline says every time a patient uses a bronchodilator, they must use an inhaled corticosteroid. I will repeat, anybody using Ventolin must be on an inhaled corticosteroid. If they are not, then they should be referred back to their healthcare provider. You can actually also use a leukotriene receptor antagonist like montelukast, and then where possible, the patient may, if the trigger is known, for example, then the patient may trigger avoid. So for example, these are patients, you're a hairstylist, and whenever you go to work, your problems get worse. You want probably to change your career. Non-Xenophilic bronchitis, this here we'll usually use an inhaled corticosteroid. And then if there's a trigger, we also avoid. For gastroesophageal reflux, you want to use a proton pump inhibitor, and we usually have dietary modifications. We usually tell the patients if they're obese, they need to lose weight, they need to change their diet, they need to eat at least 3 hours before they sleep. Those are some of the recommendations that we'll usually be able to do. Further tests that sometimes you may be able to do, this is just for nice to know, okay? For patients with esophageal reflux, this is actually how you make a diagnosis. The gastroenterologist will usually put probes in their esophagus, what we call 24-hour esophageal monitoring, pH monitoring, and be able to see is the acid is a pH high, is a pH low. So is a pH 1 or 2. If the pH is very low, it means this patient has some reflux. The patient may also have endoscopy, okay, either fiber optic or video endoscopic. Where you may not have endoscopy, you can do the good old barium swallow to actually be able to see, via fluoroscopy or a barium esophagogram to actually be able to see what happens. Sinus imaging will usually be done for patients with upper airway cough syndrome or patients who actually have allergic rhinitis, a HRCT to try and investigate for patients who actually have cough that now it's not meeting the criteria of the above. Bronchoscopy, so you do a HRCT, you see a mass, then the next thing will be a bronchoscopy. Or you are unable to find out, then you want to go and check where this patient is coughing. Cardiac workup, if this patient has, for example, leg swelling, you want to make sure you want to do an ECG and an echo. And then environmental and occupational assessment are some of the things that we usually actually do. So as you see, cough is not very simple. The causes of cough are so many. The unified airway is now what we call the nose and the lungs are intertwined. So some patients with allergic rhinitis will actually cough. Okay, so their problem is actually in the nose, but they are manifesting with a cough. Are you getting me? Sinusitis. When a patient has sinusitis, this will usually need a treatment. So for sinusitis, the patient usually have fever, they'll have headaches. This will usually require some antibiotics. There are systemic diseases that may lead to cough. Are you getting me? Local things, the pulmonary system, for example, hypersensitive airways, like in asthmatics, okay? Aspiration, gastroesophageal reflux, or laryngopharyngeal reflux may actually also lead to cough. Or patients who've had, for example, strokes and they're aspirating, this may actually lead to a cough. So cough is not as easy as we think. Okay. Now, one of the other things that this guideline in the 2018 recommends is we must actually always ask about how bad is this cough. Okay. So you ask the patient, how bad is your cough? Okay. And you'll usually grade it from 0 to 10. So you ask them, this cough of yours, how badly is it from 0 to 10? If the patient says, my God, I can't sleep at night, this thing is horrible, then this is a worst possible cough. The patient is not sleeping at night. 10. Are you getting me? And if the patient, if it's not that bad, they'll tell you it's mild, so they'll give it a 2. Then the other thing you want to see is how it affects their life. Okay, their quality of life. Are you getting me? So if the patient says, I can't sleep at night, I can't go to work, okay, my life is so miserable because of this cough, then of course that's a 10. Or this is not affecting me, I'm able to work, then you probably put it as 0. So these are what we call cough scores to actually be able to see how this cough is affecting the patient. So just as a reminder, okay, as a review, remember there is a trigger, sensitivity, the center, then the cough. There's a trigger of the airway, okay, remember the airway, then there's sensitivity, okay, your receptors, which will send information to the center in the brain, and then the brain will usually tell the respiratory system to cough. Now, management will usually depend on where the problem is, okay? So for some people who probably have problems in the brain, they may actually have a central mediated cause of their cough, but these are very rare. Okay, now let's just go to management of some of the common causes. Chronic bronchitis, this one usually seen in smokers. This is what is so-called a smoker's cough. Okay, they usually complain of irritant, some dust, smoke, things like this will irritate them. they'll usually have some little phlegm. Okay, they'll expectorate, and this is usually in most days in a 3-month period for roughly 2 years. Okay, we'll usually do spirometry or lung function and usually have an obstructive pattern. What must they do? They must eliminate the exposure. So, for example, somebody who's a carpenter, okay, or an old mama in the rural areas who cooks with biomass. Are you getting me? Or biomass being firewood or charcoal. Okay, then these are the things you want to eliminate. Okay, then if they are smokers, they have to abstain. Okay, and then you want to see if they do that, do their symptoms improve. Okay, the other one is an ACE, induced cough. Okay, basically this is what you want to do is probably switch the patient to an angiotensin receptor antagonist and see if they still cough. The reason why these patients cough is because of this mechanism. When they are put on an ACE inhibitor, the bradykinin goes up. And you remember in my first slide, bradykinin is one of those things that irritates the airway. So these patients will usually cough. And that's how the ACE inhibitors will usually cause a cough. Okay, so you block here, there's an increase in your bradykinin. And then, of course, from urine, we usually eliminate the inactive metabolite. But this thing will usually go up. If you now use the ARB, the pathway is different. So this one, it will usually come and block the angiotensin receptor 1 or 2. Usually 1 blocks here so that now you do not have, this usually reduce your blood pressure. Okay, and avoid this pathway of the ACE inhibitor. ACE here will usually cause, blocking that will usually cause an increase in the bradykinin. So you change the patient to a different type of antihypertensive, or you can change the patient to a totally different class of antihypertensive, like a calcium channel blocker or a beta blocker or an alpha blocker to try and control their blood pressure. So these are some of the things when you're reviewing, when you're reviewing prescriptions, you need to be on the lookout for. So if somebody coughs, just remember, yesterday did you dispense something that may actually cause a cough? The other thing that I'd mentioned was an upper airway cough syndrome, formerly called postnasal drip syndrome. Okay, this postnasal drip will usually cause an irritation of the hypopharynx and the larynx. Okay, this and usually manifests as a chronic cough. Okay, it will usually resolve with treatment. Some of the common causes are sinusitis, perennial non-allergic rhinitis, allergic rhinitis, post-infectious vasomotor rhinitis. Environmental irritants may actually be able to trigger the upper airway cough syndrome. Most of the time, we actually use antihistamines to manage this condition. Then I mentioned about asthma. Okay, sometimes some of these patients may actually have a cough without wheezing, without chest tightness, and without shortness of breath, what we call cough variant asthma. These patients only cough. They don't have any other symptom. Okay, so 20% of us, 20 to 30% of asthmatics will actually present with this cough variant asthma. Diagnosis will usually be we actually do a bronchial challenge, okay? Or we actually give the patient a bronchodilator and see whether their cough resolves. So management, this will usually, for asthmatic patients within 1 to 3 weeks, they'll usually feel better, and then they'll usually have complete resolution in 6 to 8 weeks. But remember, treatment for asthma is an inhaled corticosteroid, because for asthmatics, they have inflammation in their airways. The bronchodilator will only relax the smooth muscle, but you need an anti-inflammatory to take care of the inflammation in the airway. So for those ones, inhales. For non-asthmatic eosinophilic bronchitis, for you maybe as pharmacists and pharmaceuticals, you may not be able to make this diagnosis, but for these patients, we usually put them on an inhaled steroid to manage their condition because they have an increase of eosinophils in their airways. For reflux, this patient will usually complain of heartburn, okay, and then they usually have an irritating kind of cough of their hypopharynx or supraglottic, which is usually basically their voice box, okay, and 45 to 75% of gastroesophageal reflux patients, okay, may present with cough. So the patient has a cough, but they don't have heartburn, okay. So you don't. This is something again. Okay, I did not know it was that high, but in medicine I thought it was about 20 to 30, but I didn't. But in practice, I've seen this. Many patients You just treat them and you treat their reflux because you'll have tried, is this asthma? No. Lung function is normal. You've done a chest X-ray, it's normal. This patient continues to complain. They do not have heartburn, but actually this is actually the cause. Okay. Now for symptoms, they usually have either a sour taste in their mouth. Okay, so always ask for that. Do you have bitter saliva? They'll always complain of a bitter saliva or a lot of saliva in their mouths. Then heartburn. So heartburn will usually more or less suggest the diagnosis. Management will usually do a barium, or you actually do the pH studies. Okay, and we usually treat with proton pump inhibitors and lifestyle modifications. There are usually lots of things that we need to do for these patients. No eating 2 hours prior to reclining, elevate the head. They need to eat high protein and low fat diets, avoid beverages that increase their, that make them have the heartburn, or any beverages that may actually reduce the tone of the lower esophageal sphincter. Okay, management usually is if medical management refuses, then surgical management, which we call anti-reflux surgery, is usually done. For some of these patients, we may usually give them a prokinetic, so metoclopramide, etopride, to actually try and alleviate these symptoms. Moving to the gist, and this is, I was told by the sponsors to actually touch on it with regards to anti-cough agents. So for anti-cough agents, we actually have several. We actually have antitussives, okay, and this work in the cough center. Now that I've explained how coughs emanate, then now you'll understand where these drugs work from. Then you have demulcents, then you have expectorants, and then you have mucolitics. Okay, so antitussives, these ones usually work centrally. Demulcents, these ones usually work locally. Expectorants, those are the examples, and then mucolitics. Okay, now I will say categorically that I'm a member of the Respiratory Society of Kenya, and we've actually put in a restriction on use of cough syrups simply because there isn't much evidence on their use. Okay, there's lack of efficacy or data for most of these commonly prescribed remedies, and simply because the evidence is not that great. And in some situations, for example, in children, they could actually be deleterious. Okay, so there's a caveat. So antitussives, these ones will usually inhibit the cough reflex, and they usually work in the cough center in the medulla. Okay, they're usually used to treat dry and productive coughs. So an example is codeine. Okay, it works. It's a cough suppressant. Causes mild sinus depression, so you don't want to give children this. Okay, or anybody who has any CNS condition. It may usually cause constipation because it also reduces intestinal movements. Should be avoided. Children, asthmatics. It can be administered orally, mild analgesic, has less addiction. I mainly write this for patients who have terminal illnesses, for example, lung cancer, where the cause of the cough I cannot be able to treat or change. Okay, so that's where I'd use a cough suppressant, simply because in that type of patient, my options are limited. Okay, and the patient's quality of life is important. Even for people who have terminal illnesses, their quality of life, they need to, if they are dying, they need to die in dignity, so not coughing around. So for those patients, that's the only group of patients I try to codeine. Why? It could be addictive. The other one is for codeine, similar action to codeine. No analgesic, no addiction liability. It can be administered orally, has a very long duration of action. Another one is noscapine, which is an opium alkaloid, very potent antitussive, useful in spasmodic cough. It does not have any analgesic effect. Codeine has analgesic effect, so it helps in patients who have cancer pain. Doesn't cause constipation, CNS depression, or addiction. Side effects are nausea or headache. Then you have dextromethorphan. This is a non-opioid, works centrally, no analgesic property, doesn't cause constipation. Then sometimes you may actually use antihistamines, but I've already mentioned to you when to use antihistamines. These are for patients who have postnasal drip or upper airway cough syndrome. That's probably where we try and use these medications. We have the old ones, the first generation, which tend to be sedative, like the phenhydramine, chlorpheniramine, promethazine. These are useful, but they are sedating. Okay, and they may actually help where you've actually been able to elicit the cause of that cough as upper airway cough syndrome. Benzonatate, this is not very common here, but it also is a periphery acting cough suppressant. It's chemically related to procaine, so it's like a local anesthetic. And it acts on the stretch receptors, which I told you in the respiratory epithelium or the respiratory surface. Then you have demulcents. No evidence for these syrups, lozenges, linctuses. These ones, they're used when a cough is irritating, arises from the larynx. So these are for patients with upper respiratory tract infections to just try and relieve them. There isn't much evidence for this, for their use. I know you guys dispense a lot of this stuff, but there isn't much evidence for this, okay? Some of the studies done in Germany actually recommended for patients to actually make their home remedies. I wasn't able to actually put that study where, you know, tengeneza dawa yako nyumbani. They work as good as some of these things that ASGEs purport to that work. So they are expectorants. The expectorants is a different class of mucokinetics. And this one includes iodides, chlorides, bicarbonates, acetates, and volatile oils. They're used for chronic cough. We claim that they reduce viscosity of the sputum, okay, and bronchial secretion. And then you have mucolitics. So mucolitics are the only ones which have some evidence, and this is in bronchiectasis and some patients with COPD. And the ones that actually, these ones usually reduce the viscosity of sputum because patients who have bronchiectasis usually have very thick, copious sputum. So you want to help with lowering the viscosity so that you make it easy for those villi of cilia to remove the sputum. So it makes the sputum to come out easily with less effort. Bromohexine is an example. It liberates liposomal enzymes by breaking down the mucopolysaccharides. Side effects, of course, are rhinorrhea and lacrimation. Then the only ones that actually have a recommendation is actually N-acetylcysteine and remotely carbocysteine. And this is especially in bronchiectasis and COPD. They are used. They can either be used as an aerosol. Carbocysteine is actually oral, and N-acetylcysteine can actually be found as actually tablets. I've seen there's actually a carbocysteine syrup. There's actually, I think, one company. The problem with this, nausea, vomiting, and bronchospasms. So for example, if a patient has asthma, you don't want to give them something like this because it may actually make it worse. Then we have inhalational devices. I have to mention this because you also dispense this. We have metered-dose inhalers, which will usually be an inhaled corticosteroid or a bronchodilator, which can either be an antimuscarinic agent or a beta agonist. Dry powder inhalers, double inhalers, and alcoholers is what we have in the country. And then nebulizers, which you use for severe asthma and COPD and children. With that, I end my presentation. And this is a caption. I now open the floor for short speeches, which are disguised questions. Thank you very much.
Ladies and gentlemen, I'm left with no words. Thank you so very much, Dr. Andrew. I think this is more of the first class, the first day starting class, biology class, where the lecturer, the teacher was showing a cell. So for me, this was that moment of seeing the cell. Ladies and gentlemen, that is amazing. Daktari, asante sana. So just scroll out, Daktari, grab some coffee and also hold a breath. So let us invite Susan. Susan, are you with us?
Yes, I am. Can you hear me clearly?
Yes, I can hear you. As you share, let me introduce Susan. Ladies and gentlemen, Susan Okoma is the regional marketing manager at Cosmos Pharmaceuticals. Cosmos Pharmaceuticals, as we all know, is the leading local manufacturer in the country. Susan has 15 to 20 years experience in marketing. She is a great and elaborate marketer. Susan, take it over from us.
All right. Thank you very much, Mbao. Thank you, PSK fraternity. Dr. Andrew, thank you for such a fantastic presentation. I've also learned quite a bit. Dr. Lucas Nyabero, thank you for attending and giving us this opportunity. We are very much privileged. And as Mbao has introduced me, I'm the regional marketing manager for Cosmos. My name is Susan Okoma, and I'll not talk much about Cosmos because you guys are familiar, you're our #1 supporters. So my presentation is going to be very brief. So for those of you who may not know, just an overview of who Cosmos is. We are a local manufacturer of generic medicine, and we have a facility which is GMP compliant and WHO certified and European PICS certified. So we have very high standards of manufacturing. And you can see that in our products based on the experience you've had using and also from the experiences from your patients. So I'll not belabor on that. However, in terms of our facility, we do encourage you to please come and visit and actually see where these medicines are being manufactured and see how much we've invested in technology just to ensure that we are giving you what we are promising. So, and in terms of pricing, you know very well, Cosmos is one of the companies that gives affordable medicine and which is also accessible. So with this, we want to ensure we have sustainable healthcare within Africa and beyond, and also ensuring our patients are able to achieve the universal health coverage. So I'll go on to the next slide where I'll just, I know some of you may not have attended PSK, but just to let you know, this is our founder who was very passionate about local manufacturing and ensuring each and every Kenyan is able to afford medicine when they need it. And he's known as the pioneer of local manufacturing in Kenya, Dr. Prakash Patel, who was also a PSK member. However, it's sad to say that we lost him in March, for those of you who may not have known. However, I know the PSK fraternity shared communication regarding the same. So sad that we lost him, but he left a very splendid legacy. So if any of you can be inspired, Dr. Prakash Patel is a guy to look up to, and you're most welcome to come to Cosmos and meet Dr. Vimal to just share his history and what he was passionate about, the lessons we learned from him, and maybe you can borrow a leaf or two to get you where you are. So I just needed to mention that. So for us, Dr. Andrew has talked a lot about coughs and how to manage them. So we do advocate for responsible use of medicine and also following the right protocol in terms of managing the patients. We have this offer that I'm sure some of you have seen through our reps and through maybe the distributors and our social media forum. We have this offer for the cough syrups, which we do encourage you to use responsibly. We have for cost coughs, the cost cough range, Bromsal and Lohistina. So you buy at net price and get a 10% extra bonus. And again, I emphasize responsible use because that's what today's session is all about, and in future as well. So other than that, I'd just like to mention one new range of cardiovascular medicine. We do have Glycit, which is dapagliflozin and a combination of a unique combination of dapagliflozin and sitagliptin. Unfortunately, we've had sitagliptin can cause a cough where it's not, it's causing a life-threatening cough. Then we do recommend that, of course, you do not, you encourage the patients not to use it. So this is just to mention to you some of the new products we have in diabetes and in heart failure. I'd also like to mention that Dicad, sacubitril, and valsartan, and you can see the prices there. So in terms of our range of medicine, I just encourage you to go to our website. Please visit our website and get to find out the range of medicine that we do offer. And if you have any inquiry, we have that button here. Yes, I want to benefit. You can fill in a form there, and our able pharmacist will get back to you on any inquiry you have with regards to our medicine. So please visit our website and interact on what we have to offer. And most importantly, we encourage you to come and visit our plant. Then you can actually get to learn and interact with the products that you see our reps promoting. Finally, again, we just want to demystify all the myths about generics. So we have this infographic, which you'll also find on our website. It's just explaining what generic medicines are. And to some patients who may come to you and think generic medicines are inferior to the originator, this is a leaflet that you can just give them to, or help them understand what generic medicines are. And most important to know that we have quality generic medicine from a local manufacturer like Cosmos. So please be our advocates, as we thank you for the support that you've given us through and through to get us to where we are. Finally, we are a responsible company, and we do encourage you to report any adverse event. So that's the email, that's the number. We do get back to you, and anyone who has any complaint on our products, we do have a system in place, and we'll get back to you. We'll find the root cause and get back to you. So we encourage you as much as possible to give us this feedback on any drug safety concerns. And of course, this will help us to continuously improve. We are where we are today because of what the feedback that we've been getting, and we are yearning to continuously improve based on the feedback that you give us. With that, I'd just like to thank you all for giving us this opportunity. Bye. Mbao, back to you. Mbao?
Hello, Susan. Thank you so very much.
Okay.
Thank you so very much. So we now proceed to the Q&A, ladies and gentlemen. We now proceed to the Q&A. Dr. Andrew, you're here with us?
Yes, I am, loud and clear.
The first question is from Dr. Abdinur Abdullahi Ahmed. How will you manage cough in pediatrics, especially under 2? Under 2 years.
So one, I'll have to say that probably, Susan, you can stop sharing your slide. Let me put up one slide. I'm not a pediatrician, but I can probably put up one slide to just highlight some things that for even children, but even in children, there are some things that, so this is in children. So in children, you want to find out, is there a productive cough? These are the diagnoses: protracted bacterial bronchitis, aspiration, lung abscess. If your child is coughing blood, you want to think about TB, what you call interstitial lung disease, bronchiectasis, or autoimmune lung disease. Wheezing, is it asthma? Is it bronchiectasis? If a patient is short of breath, then that's different. Recurrent pneumonias, does this child have a structural disease or immunodeficiency? If it's a neonate, that this is basically a child under 1 month, then could this child be having a congenital anomaly or immunodeficiency? And then episode of choking, is it inhaled or retained foreign body? And then if this child is anxious, mainly usually this will be children, preteens and teenagers, then you want to think about a psychogenic cough. So basically for children under the age of 2, you want to find out the cause. As I mentioned before, is it infectious or non-infectious? Infectious, the child will have some fever. And they may have the other symptoms. They're irritable, loss of appetite, and the likes. I very well know that reflux can start even before the age of 2. So not all children coming with a cough, can you really just say it's a URTI? Okay, you need to know why the child is coughing. You need to try as much as possible, find the cause. Where the cause cannot be found, then that's probably where we may actually try symptomatic management with the cough syrups. But for children, it's a no-no with the cough syrup. I think somebody has put it in the chat. I think this is somebody working in Aga Khan, because I know in Aga Khan there's a total ban. In Aga Khan, you'll never find a cough syrup. In Aga Khan University Hospital, they don't have cough syrups at all. And this one was, I wish I could share, probably I'll look for that document about the restriction of use. So any person under the age of 12 basically should not be given a cough syrup. And the reason is what I've highlighted, because you don't want to give an antitussive to a child, are you getting me? Which will go and suppress their central nervous system. That could portend for problems. And then some of these conditions could actually hide the true reason why this child is coughing.
Asante, Daktari. So the other question is from Dr. Angela Ndirango. Why are cough syrups not recommended to children under 1 year, and what can one give if a child is present with a cough? I think
so for children coughing, try and find the cause. I know for you guys, I don't envy the work that you do sometimes, because parents can really be difficult. They will insist, they want a cough syrup. But we just have to practice, we have to work within the law that, yes, your child has a cough. We need to find out why the child is coughing and to actually be able to find out the reason. Some children, and I've seen some children who are actually asthmatic. So, giving them a cough syrup is not going to help. So is there a history of asthma in the family? Is there a history? So especially for children, I would hesitate giving them cough syrups until the cause is actually found. If the child has an allergic rhinitis, for example, then there may be a role for an antihistamine. If the child has a running nose and the child is also coughing, there may be a role, and does not have a fever, there may be a role for an antihistamine. I've seen another question, maybe just to not go before you. There's somebody asking antihistamines for people below 6 months. There's actually none. None of them are recommended for persons less than 6 months. None. Their safety and efficacy has not been established for people under 6 months. But if a clinician or a medic has seen this child and thinks this child has a strong history of allergies in the family and has already started showing signs of the same, then those are what we call isolated cases where you may actually prescribe an antihistamine to a child under the age of 6 months.
Asante, Daktari. So from Dr. Samuel Marami, there is a physiological rationale as to why, so probably there's a physiological rationale as to why cannabis may have a role in the suppression of cough. The cough reflex is regulated by a G protein coupled receptors. Agonists of prostanoid receptors and agonists of bradykinin receptors stimulative cough, whereas beta-adrenoreceptor agonists and cannabinoids suppress cough. With a debate on legalization, what is your comment, Dr. Andrew? Dr.
So the challenge with cannabis, you have to know that cannabis, there are those things that are called cannabinoids. There are some cannabinoids that are beneficial and there are some that are not beneficial. So I'll not recommend for people to go and start smoking weed simply because you may get the undesirable effects, the psychoactive effects from the cannabinoids that we do not want, for example, as medics. There are cannabinoids, however, on the other side, that have anti-inflammatory properties that help with nausea and appetite, and as is well said, with cough. Are we together? So those are the ones which are manufactured, where they've actually been able to actually tease out the cannabinoids, to actually be able to find the beneficial ones and remove the psychoactive substance. So just cannabis on its own, there is no role. I do not advocate for it. If they want to start manufacturing and they are able to split for us THC from the other cannabinoids, then yes, they may be a role.
That is, thank you for the well and scientifically responded to response, Dr. Now, I'm happy that today is just a medical fraternity. If a journalist was here, they would have quoted tomorrow morning in the dailies, Dr. Andrew Ward accepts cannabis use in cough. But now we all understand it's we are looking at the compound tetrahydrocannabinol. It's
bad news. THC is bad news. We don't want THC.
We don't want THC.
We don't want THC.
So what are we looking for, Dr.
See, that's what I'm trying to say. It's not as easy as just saying legalize marijuana. Because we are going to have an epidemic of mental health challenges because psychoactive substances. So CBD, yes, but of course that one will need a manufacturing process. So it may not be, the effect may not be as big as people think that, tomorrow you'll actually be able to go and get this stuff. When we now do that, it will actually be a prescription again. So you'll have to see a doctor prescribes, you go to a pharmacy, they dispense.
Wonderful, wonderful.
No, so this is not the politics about it. So this is not the politics.
It's the science.
It's science.
I believe Susan is listening. So that's something, Susan, you can pass on to the drug development department.
Well noted. Our R&D will be informed accordingly.
Okay, we go to Caroline Bungay. Is it advisable? That's a question that Daktari has well handled. Dr. First and foremost, reading from the charts, one of your former classmates, that is Dr. Mika Ajona, a respected member of PSK, says, thank you so very much for the wonderful presentation.
Oh, thank you so much, Mika. Thank you so much. I haven't seen him in a while.
Okay, a question from Frida Onsare. Thanks, Dr. Andrew, for the insightful presentation. What could be the cause of a thick, clear film, with or without cough, every morning upon waking up, and a persistent feeling of something clogging the throat? So
patients waking up in the morning with copious sputum, if a lot of sputum that can actually fill a cup or half a cup, that would be bronchiectasis. If you actually wake up and you just have some expectorant coming out, then chronic bronchitis would actually be the diagnosis there.
Wonderful, Dr. This Dr. Tadudi Ali, he's asking, what are some of the natural remedies that can be used at home for cough in young children? Honey? Okay. Yes. Honey, correct. It's been studied very well. Honey is actually good, and these are now the competitors to our cough syrups. So honey is one. Two is actually chocolate, and more so dark chocolate. So these were studies done during COVID. They went trying to look for things that would help with cough. So honey, yes, does help. And then two, dark chocolate. Cilia iko na sukari mingi. Unajua ile dark chocolate, the one that tastes almost like cocoa, that one, dark chocolate, will help with the cough. So a child can suck, and the good thing, they just suckle on it. And then for hydration, you can now add warm water, ginger, lemon, and the other things that we usually do. Those ones are for hydration. Are you saying that the ordinary chocolate in our shops, the ordinary bars of chocolate in our shops, not the ordinary chocolate, okay. Dark chocolate. People who know chocolate will know what I mean when I say dark chocolate. The one that there's that dark chocolate. It's not sweet. It's usually, okay. It's not sweet. It's like if you've drank cocoa, not drinking chocolate. Drinking chocolate has sugar. If you've taken cocoa, naturally the original cocoa, the one in an orange tin without sugar. Yeah, that one. Yes. It's chocolate that tastes like that. Thank you, Dr. I'm asking that because the men here will tomorrow buy. They could as well try. At least chocolate does no harm and it elevates the mood. So I'm good for chocolate. Try chocolate. Yeah. The other question is on by Bethany Konga. What of the herbal cough syrups are they safe and can they be given to children? As I've mentioned to you, there isn't much studies that have been done. Do your local. I am open. Use honey. Use chocolate. I'm okay with that because they don't have untoward effects. Okay. So so for me, I would stay away from all these things that people purport and they do not have a lot of science behind it. I would challenge any of you to go and check even on the net, honey and cough, chocolate and cough, and you'll actually see some data about it. Asante, Daktari. And probably not the last question, but a question here by Frederick Otiambo. What is the rationale of balancing between cough syrups that do have the combination of various classes in relation to management of the side effects? So once, if you guys know this more than I do, I always make this joke, and I was making a joke with Susan, and I told Susan, listen, I'm a doctor, I'm allowed to prescribe, but I'm not allowed to dispense. You guys, on the other hand, are allowed to dispense, but not allowed to prescribe. So we have to work together, because I saw somebody putting up a question about sometimes, the doctors insist, but you're the one dispensing, so you can say, I'm not dispensing. If you can see that there'll be drug-to-drug interactions, you are allowed to actually decline that owner. Watch out, and if he has to give, let him call you directly. You need to get a doctor's contacts and tell him, Daktari, these drugs are gonna be antagonistic, or these drugs are gonna increase the side effects. So with regards to cough syrups, you'll have cough syrups that have 2 milligrams of salbutamol, 2 milligrams of guaifenesin, ambroxol, and the like. First of all, those doses are too little to actually cause any response. And that's why, as a member of the Respiratory Society, we actually restricted the use of actually these agents. Well, Daktari, thank you so very much for your response on that. So let me probably... there's another one here. Sorry, there's another one here. Somebody asks, why do they combine antitussive and expectorant, mostly mucolytic, in a cough syrup? The answer is, I don't know.
why you would do that. Are you getting me? It's like throwing everything in there for a patient to take. You have to be clear. Am I writing an antitussive? Am I writing a mucolytic? Because there are strict indications for each and one of them. Mixing them and putting them in a pot, in one pot, just doesn't make sense. And that's why we restricted their use.
Asante for that response, Daktari. So that has been answered. And is the honey in pediatric syrup safe?
Pardon?
Honey in pediatric syrup.
So for me, just go for the honey. Don't go for the commercial thing. One, honey has many more benefits than because I'm not sure how much honey is in there. Is there, what else is in there? So for me, it's a way of trying to get us to prescribe those cough syrups. So it's still a blanket no for me. For me, it's not the honey there, it's the other things that come with it that are in the cough syrup. The honey may be safe, but what about the rest? What about the codeine? What about the fulcodeine? What about, the other elements that are there? What about the capocysteine?
Thank you so very much, Dr. Let me see. There's a question by Rufus Kuna, Chris O'Doyle. What is the relationship between cod liver oil and cough?
First of all, cod liver oil has omega-3. So it's actually the omega-3 and omega-6, the anti-inflammatories. Cod liver oil is not given for cause. Cod liver oil is given for healthy bones and to ameliorate for inflammation and things like that, for healthy growth. If it has any role in the tiniest of bits, it would be because it has anti-inflammatory properties. Because omega-3 and omega-6 have anti-inflammatory properties. But majorly we give them to adults who have inflammatory arthritis too, to help them. Patients who have joint pains, if they take them, it actually reduces their pain. It does not change the disease, but may just have a reduction in terms of the inflammation. But the joint disease will usually go on. So cod liver oil is not for cough. We give it for, for the health benefits that it has as an anti-inflammatory. So it may assist the patient if the patient's cause of the cough is inflammatory.
Asante sana daktari. So probably, let me ask a question to Susan. Susan, are you with us?
Oh, there's another one here. There's another one, Bao. Somebody asks, a patient recovered from COVID but complains of throat irritation. What could cause this? Any patient who's had COVID, this one needs a medical examination. COVID is a new disease. We are still learning every day. There are so many things that it causes. I'd recommend, if it's one of you, please seek medical attention. Or come see me.
Thank you so very much, Dr. Another question is that on the basis of housing being an influence on our health, patient is somebody is asking me on my DM, they're told to frequently bask their children in the sun. Will that have an effect in healing of the common colds and the coughs?
So with regards to, there's a role between hyperresponsive airways and vitamin D. There's actually a rule. So the reason why children have to be put out to bask in the sun or get vitamin D supplementation is to try and ameliorate for the hyperresponsive airways. So there are some children who, if you've seen children with rickets and the like, they usually also have asthma-like symptoms. So asthma is made worse if you're vitamin D deficient.
Asante on that response, Dr.
Oh, I'm here.
Now you can throw it to her.
Hello, Susan.
Yes, I'm here.
I'm seated with some of my colleagues, and they're throwing questions at me. They don't want to type in. And these are very simple questions. Eh?
Yes.
Yes. Somebody's asking a question on. You are a local manufacturer. You have had it from the logo from a consultant who understands our body as Africans. Are you working on anything probably as a natural remedy with probably Kenyan honey and mixing in some herbs as a herbal remedy, probably the ginger and garlic, and putting it in as a pharmaceutical product? And I know your R&D department is well versed. Is it something that can be done Somebody is basically asking, are they're willing to come and work for your R&D department and be able to activate the product?
We are learning and we are continuously improving. So this is something that we'll take on. Thanks, Dr. Andrew, for these tips. So yes, I can tell you, yes, nothing is impossible. So we are an innovative company, so we are happy to do that.
Asante, there's another question from my CEO who asks about the codeine, the cough syrups which are having codeine. Let me put it on and let me be able to see it. 1 minute. Allow me to.
Maybe as you check, I can answer some questions.
Yes, Doc.
Somebody asks, nasal sprays recommended for children having nasal congestion and coughs. If the child has allergic rhinitis, you can actually use the nasal sprays. That one is indicated, or a postnasal drips syndrome or upper airway cough syndrome, then it's indicated. If somebody has allergic rhinitis, then the nasal sprays are actually indicated. Somebody asks about antihistamines under 5 years. Majority, I know the loratadine and levocetirizine is, you can use it from the age of 6 months and above. For the older ones, the cutoff is actually 2 years. So for under 5, you can actually use antihistamines.
Asante, Daktari, for that response. So the CEO is asking PSK Dr. Lucas Nyabero, please comment on cough syrups with codeine for breastfeeding moms, especially for rapid metabolizers.
I've already mentioned, why are you writing codeine for a breastfeeding mother? What is the cause of her cough? So you want to find out the cause of the cough. So for pregnant women, reflux is something that increases as the pregnancy advances, because as a baby, as a fetus grows, they usually displace the tummy. So for pregnant women, as the pregnancy continues, they'll usually start complaining of a lot of reflux, or they may have bloating simply because this baby is sitting the whole time and there isn't room for these matumbos to do their usual work. So this is somebody you want to actually make sure they don't have reflux. You're not going to give codeine for somebody who's having reflux. So for me, it's, you need to know the cause. I'll not just give, a pregnant lady, of course, doesn't want to cough for obvious reasons, but you're not just going to write codeine. You're trying to find the cause of their cough. Do they have postnasal drip syndrome? Do they have asthma? Because asthma can be triggered by pregnancy. You may never have been asthmatic. You get pregnant, your asthma starts. You get, and you may actually have allergies that come when you're pregnant, that when you're not pregnant, they're not that bad. But when you get pregnant, because of these hormonal changes, you actually have these allergies coming in. So for me, it would be nice to find out what is the cause before you throw in codeine. As I mentioned, codeine, I'll give it to terminal patients who either have interstitial lung disease that is terminal, or lung cancer that, you know what, there isn't much I can do, and they are coughing. Those are the patients who are actually prescribed for that.
Asante, Daktari. So another one from Dr. Peter Odhiambo. He is a regulatory affairs pharmacist and a very vibrant young pharmacist. He asks, this one study says dextromethorphan, that is pathophysiology. Dextromethorphan causes a rebound expectoration. Expectorants are thus justified. Do you, Daktari, have a start of this?
Pardon? Yeah, as I mentioned before, dextromethorphan may actually cause rhinorrhea and rhinorrhea. So it may actually have an increase. You may actually have an increase in expectoration. But as I mentioned, you want to try and tease out the causes first before you start giving this cough syrups, because those cough syrups, you'll only try and use them where you are unable to decipher the cause of the cough. As I've mentioned, if a client comes to you and they say they are coughing, you must ask, do you have fever, or take their temperature? Number two, when is this cough worse? If the patient says baridi, vumbi, moshi, and things like that, this is an asthmatic you're probably dealing with. You will be able to make a sale that day, but that patient will not get relief from their cough. I speak that way because I am in the back end. There are many people who have come, they've taken cough syrups, they've been given several courses of antibiotics. Then I ask them one question: when do you cough most? Daktari silali usiku. Finished, that's it. So for me, asthma moves to the top of the list. Are we together? So you're not gonna be, the reason why we've as PSK brought up, is so that people are not trigger happy dispensing cough syrups.
Wonderful. Thank you so very much, Dr. There is the last question by Gaius. Could Dr. Andrew just quickly revise NAEB and its NAEB and its common symptoms? Like I had him mention something about eczema. I didn't get clearly, Dr.
So non-asthmatic eosinophilic bronchitis. This is a rare diagnosis, probably be made by maybe a chest physician. Maybe you get me, simply because we usually do what we call a sputum study and check. And this by the time you get that diagnosis, you've eliminated all the other common causes of cough, as I've mentioned before. With regards to allergies, if somebody has allergy and they have a cough, asthma is number one. You need to rule out asthma. And that's where these other things came in. Maybe just to reiterate, I mentioned about allergies being 5. If somebody says they have an allergy, they have to be specific. Which allergy do they have? Do they have the one for the eyes, which we call allergic conjunctivitis, which is usually itchiness of the eyes whenever they're exposed to cold, dust, smoke, and things like that. Number 2 is allergic rhinitis, running nose, okay, which is triggered by dust, cold air, usually mainly in the morning. That person, when they wake up, they wake up, achoo, asibui. That's allergic rhinitis. Number 3 is asthma. Usually they'll have cough, they'll have shortness of breath, and they'll have, they may wheeze or not. Majority of our asthmatics don't wheeze, they just cough, and they may have shortness of breath. The hallmark for asthma is the symptoms are variable. Okay, so the symptoms just go up and down. Today is a good day, tomorrow is a bad day. Completely bad day, they can't get out of bed. Again, the triggers will usually be cold air, dust, smoke, emotions, laughter, kicheka, anaanza kukohoa. Are you getting me? Those will be some of the triggers. The 4th in the family of allergies is eczema or allergic dermatitis. Usually during like cold season, like right now, they usually have a rash, especially usually in the arms. Or in children, sometimes with the face, it really itch a lot. It comes and goes. And then the last one is food allergy, usually to protein. Eggs, akikula mayai, they start itching or they have severe abdominal pains. Now, when somebody says allergy, those are the 5 things that they have to talk about. Iko kwa macho, kwa mapua, kwa kifua, kwa ngozi, ama kwa tumbo. Now, if a client has any of those and they are coughing, the diagnosis is asthma 90% of the time.
Asante Daktari. Probably you can grab a glass of water as we answer. Dr. Susan, are you with us?
Yes, I am.
So a quick one from gentleman. Oh, you have already answered, eh?
Yes, on Proguanil, yeah.
Yes.
Yeah, it's available. So please just get hold of one of our reps, or just get it from any of our distributors. We have stocks available. The name is just Proguanil. It's a generic product. So we don't have a brand name. It's called Proguanil, but from Cosmos.
Wonderful, Susan. So probably, Susan, are you able to give us your parting shot for this meeting tonight?
Well, from us and from Cosmos, it's a big thank you. Thank you, Mbao, for coordinating this. Thank you, PSK Fraternity, for attending. Thank you, Dr. Andrew, for such an excellent presentation and engagement. I mean, it was quite interactive, and for us, this is continuous. We'll have more meetings, and let's continue supporting each other to ensure our patients are happy, safe, and they can access medicine.
Thank you so very much, Susan, and probably for our listeners and for our participants for tonight. What is the next webinar that you will want us to host with Cosmos? Kindly drop that on the chat box. We can use that in future to review what we want to hear from Cosmos. Dr. Andrew, what is your parting shot for tonight?
So, as I mentioned, I think I already made my parting shot, but just to summarize, one is just don't dispense because you can. Try and use a rationale. Try and find out, does this patient have common causes of cough? And if they do, then direct them responsibly. Let them be seen by a medic. And where it is absolutely necessary that you must dispense, then please dispense something that you're sure will not harm the patient. And that will be my parting shot. And that's why we have almost exclusively restricted for under 2s cough syrups, because they are not safe for that group of persons. We need to look for alternatives, and I think that's something for our research and development. And I think these are things that we can do locally with such wonderful partners, local manufacturers like Cosmos. And I like the fact that somebody asked, why can't we come up with our own remedies? I think maybe Dawa could probably be it, but probably just need to do research on it and see if it would help patients with a cough that we cannot be able to establish the cause. Thank you so much for listening and for paying attention for 1.5 hours. Thank you so much. Still about 500 participants on this webinar. Thank you so much.
Asante sana, Daktari. Thank you so very much. So for those who are asking Daktari's presentation, this is probably to alert you is that we usually have this presentation on the, this webinar is being recorded and it shall be on our YouTube page. Our YouTube page is at the Pharmaceutical Society of Kenya. And as the normal YouTuber who says, kindly subscribe to our channel, you'll get the notification. Click on the bell for that. As I probably type in that, let me probably hear out of the voice of our wonderful CEO giving his parting shots. Dr. Nyabera, are you with us? Dr. Nyabera, are you with us? Okay, so probably I believe it's a bit okay. You may be trying to join in. Ladies and gentlemen, Susan, I see there's a suggestion from Naomi Jenga. She suggests diabetes management after today's webinar, so we can work and follow up on that.
Fantastic, we'll be on it.
Asante. And langu ni kuwashukuru sana wadhamini wetu wa siku ya leo, na nitakumshukuru sana Susan Okoma kwa kuhakikisha kwamba tumekuwa na somo nzuri, na pia kwa mkufunzi wetu wa leo Dr. Andrew Award, tunasema asante sana, shukran za kutoka moyo wetu, kutoka moyoni mwetu. Shukran sana daktari. Ama kweli tumefika tamati wa siku ya leo. Sina mengi leo ila kuaga na kuambia tupatane juma lijalo katika somo letu la kila wiki katika huu mtandao. Sina mengi ila kuaga, muwe na usiku mwema. Alamsiki.
Alamsiki.
Alamsiki. Thank you, Mbau, for the great moderation. Good job.
Excellent.